Cliff and Ralph, thank you very much for inviting me to be here. It's always dangerous to speak after Joel Cooper, and even more dangerous to speak before him. And Joel has offered to give a recap of the net as well following my talk. So I'm going to try to keep this brief because, in all honesty, Dr. Cooper can almost always provide a more erudite discussion than I'm able to. So I'll cover some of the basics about the net, and I'll be as interested in all of us to have the recap from Dr. Cooper. So I don't know, sandwiched, between Joel, before and after, that has to be the worst possible scenario. So we provided this new operation for lung reduction surgery, providing a gift to the world, the breathless, the weary, the hypercarbic, and giving them a chance to have improved quality of life with lung volume reduction surgery. And if we look at the early experience before the net, the first 7 publications were all very positive. We had a sizable number of patients, over 700, and on average in these publications there was a 60% improvement in FEV1, approximately a 50% improvement in 6-minute walk, nearly 2/3 of patients liberated from oxygen with an acceptable mortality and morbidity. And so those were the publications. Now, simultaneous with this, Medicare ultimately developed a CPT code for LVRS, and once they did, they were able to track 722 patients operated on between October of 1995 and January of 96. And it's interesting to see that in this cohort of patients that mortality at 3, 12, and 18 months was quite high. Now, this may represent mortality of a group of patients that are very ill, but that raise the questions of whether this may be an adverse outcome from lung reduction surgery. And if we looked at it another way, rehospitalizations at 12 months were 40%, and if we look at the year prior to LVRS, there was 2,300 inpatient days. The year after LVRS, 5,700 inpatient days, and that excludes the lung reduction operation hospitalization. So this raised some questions about whether lung reduction was good for everyone, or at least good as it was being performed. And Joel put this up in another way, but this is the question. Let me get this straight. Removing a lung will help me breathe better. So this led to the National Emphysema Treatment Trial that I'm mostly going to talk about what's happened since the trial. I think most of you are familiar with the trial, a prospective randomized trial of lung reduction compared to maximal medical therapy. One of the key components of a trial like this is coming up with a catchy name. In this case, the net. And it's very important to be careful how you choose your name, because names can be misconstrued. As one can tell from this store, the Mega Flick store, for some reason, is never called that. And some might say that about the National Emphysema Treatment Trial as well. So in the net, the primary outcomes were survival and maximum exercise capacity, with secondary outcomes that we'd expect, looking at selection criteria, quality of life, and cost effectiveness. And I'm not going to go through all of that. I think most of you are familiar with those results. I wanted to reemphasize a couple of points. One is a very high degree of treatment adherence in the randomized patients. A large number of patients randomized, and nearly all of the patients, a higher percentage than we anticipated, adhering to their assigned medical therapy or their assigned surgical therapy. And at the end of the day, most of you are familiar with this as well, we found 2 characteristics: distribution of emphysema, that is upper lobe and non-upper lobe, and post-rehabilitation exercise capacity, which divided the cohort into 4 groups that, if we excluded the high-risk patients that were identified mid-trial, result in these 4 groups of upper lobe low exercise, upper lobe high exercise, non-upper lobe low exercise, and non-upper lobe high exercise. And just to summarize the outcomes, the green is good, red is bad. There are a high-risk group of patients that had a high mortality and should not be operated on. There's another group of patients with non-upper lobe and high exercise that clearly had negative outcomes. The best outcomes being in the upper lobe, low exercise capacity patients. This group of patients having an improvement in survival, an improvement in exercise, and an improvement in quality of life. Those that had high exercise capacity also had improvements in exercise capacity and quality of life, but did not have a survival advantage. So interestingly, all of us surgeons were somewhat cynical about Medicare and their role in this, and the fact that they withdrew support for a procedure, forced this trial upon us that we conducted, and then whether they were actually going to support lung reduction surgery subsequently. And 3 months to the day after the trial was published, actually Medicare issued a funding decision for lung reduction surgery. Those patients that met the NET criteria with upper lobe predominant emphysema. This then resulted in an accreditation process. They looked at NET clinical centers, all Medicare eligible lung transplant centers, and this resulted in a total of 45 centers that could do Medicare lung reduction surgery in the United States, and they delegated to our accrediting organization, hospital accrediting organization, the responsibility for developing additional criteria for accreditation for lung reduction centers. So what has happened since then? This is really what I want to talk about. Has there been a big expansion of lung reduction centers in the United States and a proliferation of the procedure like you would expect from a positive outcome? Has there been other NET data? And I'm not going to go over this. There's really a lot of data, most of which we're not as interested in. And then, of course, we're going to be talking about, in this session, about the technological advances in endobronchial lung reduction as well. So what about the expansion of LVRS centers? There were 45 initially approved, and since the accreditation process, only 3 additional centers have applied for an approved accreditation. And so this is the spread of centers in the United States that include the 3 new centers accredited by the JCAHO. So that one would think that the procedure would proliferate. And if we look at the numbers that we have from Medicare numbers, in this 3-month period, there were 722 patients operated on. This is at the beginning. This is the same year that Joel's paper was published in the Journal of Thoracic and Cardiovascular Surgery. 240 procedures per month being done in the United States. If we look at right after the NET was published and right after the Medicare approved payment, in 2 years, there were only 324 patients, or 13.5 Medicare patients per month in the United States. And I thought, well, maybe this is just ramping up. They're going to start doing it soon. People are just out of practice. And I looked again at 2006. It was 146, and I got unofficial numbers for 2008, which was approximately 150. So essentially, we are staying at about this number, approximately 150 Medicare lung reduction surgeries done per year in the United States. So this is a huge, huge decrease in lung volume reduction surgery since the NET, and it hasn't increased. So what is the reason for this? There could be a lot of reasons. It could be access for patients. It might be a poor understanding of the NET results from either physicians or the media or patients or all of the above, or maybe it's due to cost. And so I just want to look at these potential barriers to lung reduction surgery. So in the United States, we have 48 centers for 300 million people. That's about 1 center for 6 million population. They are not distributed evenly geographically. If we just look in the western United States where I am, there's 4 centers in Los Angeles, and there's 1 center in San Francisco, and we're the next center in Seattle north of that. Thousands of miles in between centers, yet some cities have multiple centers. So they're not evenly distributed. So why are there so few centers? And I think this is a very challenging question. Medicare certainly restricted access to sites initially, but created an accreditation process for centers that wanted to become accredited. But this is a two-edged sword. If there's not many procedures being done, it may be that centers don't see a value economically, clinically, or otherwise in going through the work and becoming accredited. But of course, if they don't become accredited, then they're not doing the procedure. So that is kind of a circular problem per se, but I think is closely related to the problem of limited access. Then we have the problem, I think, of a poor understanding by physicians, and I'm sure that Dr. Cooper and I are on the same page on this, that although there was appropriate skepticism from early case-controlled series, and even we might disagree about the equipoise resulting in the net, but certainly since the net, there is an enormous misinterpretation of all of the results of the net. A misinterpretation of the high-risk results, a misinterpretation of the final primary outcomes, and a misinterpretation of what the patients want. So this is an editorial in one of our surgical journals 3 years ago now from Claude L'Enfant, who was the head of the NHLBI who helped support the trial. And I just want to point out that this is a quote from Dr. L'Enfant in the Annals of Thoracic Surgery. NET supports LVRS for upper lobe, low exercise. In other groups, surgery did not improve mortality, and improvement in exercise or quality of life was variable or insignificant. This is blatantly incorrect. I mean, I can't believe that we allowed this to be published in one of our journals. This is not a correct assessment of the outcomes of the NET. There were improvements in exercise in all upper lobe patients. And in fact in the initial outcomes of the NET, there was improvement in quality of life in the non-upper lobe and low exercise patients as well. So Dr. L'Enfant has issued an editorial that is misconstruing the results of the trial. And in fact this poor understanding by physicians, I think, is misunderstanding what patients want. Patients want improvement in quality of life. Patients are not coming to us asking for improved survival. They're asking for an improvement in quality of life. And yet physicians evaluating the NET are focused on this NET subgroup that had a survival benefit. And this same editorial says only the upper lobe, low exercise subgroup experienced significantly better survival. This undoubtedly reinforces the conclusion that upper lobe, low exercise patients are the ones. This seems to imply that all others are not the ones, but these are the ones to be carefully considered for LVRS. And this disregards the improvement in exercise and quality of life in the other subset of patients in the NET. And then our media has followed on. So this is an article by Gina Colato in the New York Times that I had a lot of discussions with her about, trying to rebut her conclusions. Her main point in the article is that there was no lengthening of life for most patients. Well, that is true, and we're not trying to lengthen life. And a nearly 10% mortality, which is incorrect. I mean, the net mortality of the group when we eliminated the high-risk group was 5%. There's only one sentence in this New York Times article about improvements in exercise and quality of life, and the remainder of the article is about the high mortality and high cost. So this is what's being delivered to the public. So this results in a poor understanding by patients. So this corresponds, though, to physicians and media pessimism, that our physicians, the pulmonary physicians, say, well, our patients really don't want the risk. But I'm trying to figure out which patients are better informed. We had a group of patients, a lot of them, who underwent LVRS in the mid-90s. Were they ill-informed? Were they just jumping on a fad, and were they disappointed with their outcomes? I don't think so. I think these people are very happy with their outcomes. My lung reduction patients are some of the happiest patients that I've taken care of. And yet, we have very few patients in the years after the NET. Are they somehow better informed about their risks and better informed about their benefit, or have they been directed away from lung volume reduction surgery by their pulmonary physicians and the media? And finally, some would say, well, it just costs too much. And that can be true. That depends on how you look at it. It does work, but the cost is $30,000 to $60,000, and it may be even more than that. And the question is whether it's cost effective. And cost effectiveness is a slippery slope, and it's a difficult line to draw. If we look at cost effectiveness in lung volume reduction surgery projected out at 10 years, it's approximately $50,000 per quality life year. And if we look at 3 years, it's similar to cost effectiveness of lung transplantation. So certainly it's an expensive therapy, but it has evidence that it's cost effective as well. So there's a lot of additional data regarding the NET. This is just some of it. There have been now approximately 50 papers published from the NET. And I think that we can agree that in patients with upper lobe emphysema, lung reduction surgery improves survival, exercise capacity, and quality of life. Functional improvements may gradually disappear, but they do much better than their medical counterparts throughout the 5-year period. And we should continue to push for consideration of lung reduction surgery for our patients with emphysema. Thank you very much.
Thank you very much, Doug. Thanks for the data. I didn't know that it was so dramatic in the US. I knew it was, the numbers were going back, but it was dramatic. And now we go back to Joel, as I heard.
Yeah.
This is the sandwich strategy. Re-evaluation of the NET study. There was much criticism